conditions are kept manageable. They'll also reduce costs by developing what they call accountable care organizations. Now, accountable care organizations are a group of providers that agree to take responsibility for a given set of patients. They are supposed to promote evidence-based care. So if a patient comes in, for example, complaining of a sore throat, the protocol for evidence-based medicine would be you examine the throat, you examine the lymph nodes, you do a quick strep test. If the quick strep test comes out negative, you prescribe salt water, gargles. If the person does have a strep throat, you prescribe an antibiotic. It's a generic form of the antibiotic. You don't go to the high-end antibiotics in most cases because it's not going to help them get better any quicker. The accountable care organizations will be encouraged to promote quality, to reduce their costs, and coordinate care. So an individual will not have the same blood tests run by the cardiologist that the internist just ran because they're all working together in a coordinated mode. Any cost savings through Medicare that occur will be shared with the providers in the hospital. Now they're going to penalize hospitals who have readmissions that could be prevented and who have patients who develop hospital-acquired conditions. So if a hospital is not doing its job, in other words, it releases a patient home without adequate home health care, without the oxygen that the patient needs, without appropriate drugs, without home health care, and the patient gets readmitted to the hospital within 48 hours, that hospital is going to be penalized. They're not going to get back everything they paid for the readmission of that patient. Similarly, we know that there are some basic ways that we can prevent hospital-acquired infections. And if hospitals have patients who get these infections because of poor hygiene, they're going to be penalized. Another proposal is to bundle payments so that you get X dollars for hospital care, physician services, outpatient hospital services, post-acute care services, in an effort to reduce the spending and improve the quality of care. So a patient who's complaining of chest pain goes to see the internist, ends up in the hospital, has a procedure done to open up the arteries, gets discharged. All that would be paid for by one check. And so there's the hope that it will encourage efficiency and coordination in the system. We're trying to reduce inequality. A good example is inequality in gender. Many insurance policies exclude coverage for a woman who is pregnant when she applies for the policy. Women will no longer be charged more for care than men, more for their health insurance than men. And women will no longer be charged more for their care. Health insurance is going to be available to the poor minority individuals if they are citizens or legal immigrants. Coverage of preventive care will result in earlier detection of things like cancer, diabetes, hypertension in groups who delay seeking care because they can't afford that screening test. And there's a mandate as part of the bill that the government must monitor trends in healthcare disparities. Emphasizing primary care and trying to get primary care providers out into underserved areas will increase equality in care. There's stimulus money to train 16,000 more primary care providers in the next 5 years. And there's a move to increase the income of primary care physicians so that people just don't decide to be surgeons because they can make more money. Inequality will be eliminated because pre-existing conditions cannot exclude people from coverage. This is true now, today. Children can't be excluded. By 2014, adults can't be excluded. And by 2014, all new health plans must provide comprehensive services, caps or limits on out-of-pocket spending, no cost sharing for prevention services, and no annual or lifetime limits on coverage. Most of the benefits under the Affordable Care Act will go to lower and middle class individuals who are not poor enough or old enough for the current federal programs. They will be paid for by taxes on wealthier Americans and by fees assessed on the healthcare industry. And we expect that these will gradually shrink healthcare expenditures and reduce the federal deficit. The Affordable Care Act represents a framework. All the details are not worked out yet, and many of the details are going to be implemented through regulations established by the Department of Health and Human Services. They'll be phased in. There's a specific timetable for the bill. It will provide people with more benefits, greater security, and less cost for health care. You do not have to change your insurer or your doctor. And insurance and medical treatment will remain mostly private. The Congressional Budget Office estimates that the law will reduce the deficit by $124 billion over the next 10 years. So, what's the bottom line? Well, as a medical sociologist, we found that our healthcare system is fragmented, expensive, and we get very little bang for our buck. We have persistent inequalities across social groups that impact their health as well as their access to health care. And the Patient Protection and Affordable Care Act gives us an opportunity to address these issues. So thank you very much, and I'll be glad to answer any questions.
There was an ominous sign this morning on the news that the President has announced to the governors that he's willing to renege, or he doesn't use that term, modify the requirement for flexibility purposes that states must require purchase of insurance.
Right, so states can opt out of parts, he's saying, of the Affordable Care Act, but they can opt out of parts of Medicaid and nobody did it.
Well, but 16 states have sued already, isn't that right?
Right,
so
but they haven't gotten very far.
They've gotten 3 out of the 6 cases have been found in their, or whatever, found in their favor. Does this indicate that he thinks the Supreme Court would actually overturn this act?
There's those people who are good researchers on these topics really feel that it's not going to be overturned, that there's a lot of screaming and yelling. When Medicare and Medicaid went into effect, it was so controversial. I mean, people wanted to close it down.
Oh, really?
Oh, yes. Physicians were up in arms, and physicians made out like bandits because of Medicare and Medicaid, because they got usual and customary fees, and so right before that bill went into effect, all physicians raised their usual and customary fees. So it's going to be in the courts, but I really think there's so many problems with the huge number of uninsured that I don't think the act will get overturned. It's possible that certain provisions might get overturned, like providing anything having to do with abortion and birth control and things like that, but no, I don't think so.
I just wondered, based on the contributions to this journal, so a lot of the rhetoric was around choice and freedom, whatever. Mm-hmm. And so based on the current profile of the uninsured, is it known about what proportion are people who have access to affordable health care but truly do choose not to have health insurance for whatever reason?
The only group that seems to opt out of having health insurance are young adults, and they opt out because they feel they're invulnerable and they're not going to land in the hospital, and they would rather spend their money on iPods and iPads and things like that. The data